Check, check, check. Toast, toast, toast. All right. And we are live. Hello, everybody. Thank you for joining us today on What's the CO2. I am your host, Matt Martinez. And today, on our inaugural episode, I thought we'd start off with a banger. And we have Dr. Jason Kruse joining us today. Dr. Kruse, thank you so much for coming on. This is going to be a wonderful conversation. I'm very much looking forward to it. Thank you so much.
I appreciate the invite.
So let's start off on a bit more of a personal note. Um, you built your career right here in Des Moines, and correct me if I get any of the timeline mixed up, but you went to DMU, Des Moines University. You did your residency at Iowa Methodist, and then fast forward to now, um, you are at the same hospital that you and I work at. What kept you here? What kept you local?
I think some of it's just happenstance. So I grew up in Fargo, North Dakota. I went to school in Sioux City, Iowa, at a college called Briarcliff University. Met my wife there, and so as we were dating and getting serious, it became a conversation about where am I going to med school. Had opportunity to go back to North Dakota, which she didn't want to do. Opportunity to go down to Kansas City, which was a little big for my taste, and then Des Moines University was a nice spot in the middle. So landed at DMU. Really enjoyed the experience in Des Moines. I had an opportunity to follow on rounds over at Methodist. It must have been my first year of medical school because I think I skipped biochem. We're not supposed to skip class to do that. But they weren't keeping head count. I just had the opportunity to go on rounds. And I remember following with Dr. Yost, who's now working his way through. He's no longer the program director over there, but uh, followed along, saw everything. I remember seeing a brown recluse bite that had to go in for surgery and a heart attack and a pneumonia and thinking, wow, this is kind of an amazing career path, and really enjoyed seeing the residents. And so over the course of med school, knew that's where I wanted to be. I'd looked around through the upper Midwest for next steps for residency. Loved Des Moines, matched my first choice, which was really exciting for me. And then as I was coming through trying to figure out what I wanted to do with my career, I wanted to practice full scope medicine, so inpatient and clinic, and had thought that I would have to go to a smaller town to do that. But as I was coming out of residency, one of the now former partners was planning on retiring right around the same time I was going to be coming out of training, and so it all fell into place. And so I went from really not knowing where I was going to go at the start of my intern year to being signed on with a kind of a letter of intent for Broadlawns by the end of it, and that, right? We knew where we were going to be, so within a very short time frame, I joked that I became a real adult because we went from I'm in training, I could go anywhere. What do I want to do with my career? To I'm going to be where I'm at now. We bought a house, got a dog, and started building a family. So
It's really the dog that's the kicker for true
That
adulting,
is that
right?
is that that was the test run, right? I figured if you can make the adjustments for a dog where you can't just bolt off after work and be like, hey, we're gonna go out for drinks, or we're gonna go meet up with friends. It's like, first I got to get back across town, go let my dog out, and then I can meet back up. And if you're willing to make those changes, I feel like it's a lot easier to adapt to kids.
Oh yeah, absolutely. I'm going to Houston next weekend, and yeah, the one thing I'm just gonna admit that we always seem to forget until like 2 or 3 weeks is wait, what are we
Yeah,
gonna do with the
yeah,
dog?
it's a
Like,
totally different experience. I grew up with cats, and my parents could just leave out food and water, and it was all good. Someone would check on the cat periodically, but it's not the same thing as a dog where you have to have a real plan for it.
oh, that's hilarious. I love it. So to fast forward a little bit, you have some pretty substantial and have had pretty substantial roles at Broadlawns Medical Center. You are you currently the chief medical officer? Is that correct?
No, no. So I was chief medical officer for 8 months, a couple of years ago, and so it was Dr. Shaw was our guy first. So I took over, would have been officially in July, but effectively in June when my predecessor had already made the arrangements for me to take over in July and said, by the way, I'm going to climb Mount Kilimanjaro. Can you cover for me? And so I took over a little bit earlier than initially slated as kind of the effective role, but had the opportunity to do that, and carried that through for I think it would have been about 7 months officially, and then some transition through.
Okay. But then you are also the interim CEO?
Yeah, yeah, that was a different experience. And so I took over the interim CMO position June, July, and then it would have been uh, end of October, beginning of November, because I remember it was like Halloween week, I think, when things kind of happened, and the guy that was in the slot was leaving, and it was somewhat short notice, and so I got the offer to step in and took it, and it was unexpected. I'll say that. Yeah.
So when you're asked to be interim CEO, was did you kind of know beforehand that you were potentially up for the position, or was it more of a sudden thing? How that whole process lead up to that?
Yeah, it was pretty sudden. I think there's some stuff on the backside that I was unaware of. And then when the decision was made, there's going to be a transition. The board, right? We've got a publicly elected board that runs things. And so they made the decision that this was going to transition out. And I don't know the details of how I came in as the person to ask necessarily, but they asked, and it was a pretty quick yes. I remember they asked if I needed to talk to my spouse about it. And I said no, she'll be all right. Uh, she's kind of rolled with the punches. We've been together since I was getting ready to apply for medical school, and she's been through an awful lot with me. And so I was like, oh, it's just kind of one more thing. And so they thought I was crazy, and probably she was crazy, but went for it. And so I got the call. I said yes. And then that night, I was helping. I did my son does scouts, and so I was like at this scout meeting, trying to navigate these kids, and thinking like, okay, I got to tell my wife about this, and I need to figure out what I'm doing tomorrow, right? And got home, and I told my wife after we got the kids settled in, and her first statement was, I don't know if you're qualified for that,
Oh man.
which which was perfect, right? I was like, yeah, you're right. I get that. This is not my long-term plan. But for the short term, it makes sense. And I think a big piece of it was we were transitioning, and so I was the least experienced executive, but the longest tenured person at the facility among the leadership team, right? And so being able to kind of leverage those connections worked out. I had a lot of experience within the different committees at the hospital. And so I had a pretty good understanding of where we were as a facility. I'd been there for around a decade at that time. And so I think that helped a lot to be able to do that. And since I'd been in the leadership circle already for 5, 6 months at that point, it made it a lot easier to make the transition. I'd been part of the meetings, I'd been part of the strategy sessions, and I could kind of keep things moving forward.
Was there ever a point during that time as your interim CEO that it could have been permanent, or you for sure knew throughout the whole time, like, I'm not doing this forever, like this is temporary?
I knew that that was not my spot to go to. So I think I'd never really looked at administration as a major piece of my career plan, if that makes sense. I think as I was coming along, I really enjoyed a lot of aspects of it, but being able to do it long term while balancing patient care would have been impossible, right? So the whole time I was doing these roles, I was still taking call, I was still doing my weekends, I was doing less inpatient, but I was still doing inpatient. And since I was not planning on making it permanent, that meant I had a clinic to maintain, right? I've got patients that I've had since I was literally an intern, and so that's a long time to have those people. I couldn't just hand them over to someone else and expect to pick them up. And so going through it, knowing that I wasn't ready to step away from patient care most of the way away from patient care made it an easier decision to say, I'm not putting my hat in the ring. I'm not going to apply for this. But there were a couple of moments of like, well, I think I could do this. I think it would be, kind of an exciting chapter. But I think once you're in that world, if you really give up your clinical role, it's really hard to pick that back up. I think medicine moves so fast that being able to step back into that would be tough.
Um, you had mentioned your wife being a part of this. This isn't a part of what I gave you in the notes, but medical school, just being in healthcare in general, is a very demanding career. We have odd schedules. I mean, you're on call like 24 hours at a time sometimes. How important is it to have somebody alongside you that is understanding of the demanding role of healthcare? I mean, could you obviously? I'm sure you could see your career going very differently had your spouse had a different perspective on certain things.
Yeah, I think it keeps me grounded. I mean, obviously, she's willing to just say, "Hey, here's how it is," which helps a ton. I think having someone that you can go home to and share that space with, and share the ups and downs with, matters a lot. I think having a way to step away from medicine world is great. She's not in the medical field, and so that makes a big difference too, because we're not sitting there trying to navigate both of us having wild schedules, and we're not trying to decompress from the same types of things. So she was a middle school teacher for a few years before, 5 years before we had kids. And then she stayed home, and now she's working part time again, but she was going through. And so I'd come home, and it didn't matter kind of what my shift was. She'd still have her piece from teaching middle schoolers, which sounds wildly difficult. Uh, and so I kind of liked hearing that other side of the world. I think it's nice to know that there's something outside of the walls of the hospital. We can get a little um, not only self-inflated with what we're dealing with, because it is life and death and in a lot of cases, but we lose perspective on what the world is outside, and what other people's daily life is. And I thought that was really great to have that. I love now that I can transition out and I can pop home and go into husband mode or dad mode, and my wife will listen if I've got something I really want to talk about. But if I don't, she's kind of adapted the fact that I'm gonna kind of flip back in and I want to get on with normal life. And I'll tell you, a 5-year-old doesn't care what you did or what your job was. It doesn't matter if you were in charge of a facility or if you were a physician or what you were doing. They want you to read a book, build with blocks, play Paw Patrol, do something. It has nothing to do with your regular day. And I think that's an awesome way for me to step back into the real world.
What would you say is the most or some of the most intangible qualities that a physician can bring? Is it clinical humility, compassion, being present with a patient when they're having conversations, moral clarity? What are some of those traits that you see that are invaluable?
Yeah. So this is going to be maybe a little counterintuitive, but I think compartmentalization, the ability to um, pivot from one situation to another, and then be able to pivot back to the real world and get back to work, is a huge piece, right? When people are talking about physician burnout or physician success, I think the ability to go from a room where you're delivering good news, hey, your pneumonia is getting better, you get to go home, then go to the next room and you've got something devastating to deliver about someone's cancer diagnosis, or the fact that you're not going to be able to fix whatever their ailment is, and being able to do that and maintain your perspective for the moment and maintain your emotional tone appropriately, is a real specific intangible set that I think is something that you either learn to do or you don't. But I think that that is really important, because I think if you are really good with logic puzzles, I think you can do really, really well with medicine, but you won't necessarily be good with people. And I think if you've got reasonable emotional IQ, you can do really, really well at the bedside, but it doesn't mean that you're going to make good decisions or guide people to an appropriate choice as we're navigating their healthcare problems. And if you are maintaining your clinical humility or your curiosity, these other things that are really important, but you can't make those pivots really in a minute to minute notice. I think it's hard to succeed.
So it seems to be there's like a knowledge aspect of it, and then there's the emotional, social aspect when it comes to traits that a great physician requires. I would think it's more difficult to acquire those social, emotional awareness uh, tangibles as opposed to the knowledge based ones. Would you agree or disagree?
Yeah, I think that there's you can take most people and you can teach them to run the logic circuit piece of it. I think there's certainly some risk of kind of hitting a wall, so to speak. But it is tough to teach some of those interpersonal skills, right? I think that you can become take someone who's got good emotional capabilities and good social skills, and if they've got a reasonably logical mind and they can again separate out, because sometimes it's hard to do that and get into the logic puzzle piece of it. I think you can train that a lot more easily than you can train in somebody who doesn't have good responses to social cues or is very uncomfortable with emotionally charged situations, and making them become comfortable can be hard. I think part of the benefit of the prolonged medical education pathway is that you get exposure therapy, more or less, right? You spend 2 years in clinicals or maybe 3 years in clinicals, depending on what your school is set up at, before you even go into residency. And then you get another 3 to 7 years or longer of additional training where you're forced to do that in a semi controlled, you're flying with a net, you're not on your own. And so if you've got a conversation that goes sideways, you can take somebody else in to help clean up or help navigate. And usually people are aware enough to know by the time they hit residency whether or not they've got reasonable bedside manner, if people tend to respond poorly to them in some situations. And so navigating that, I think, is hard.
Is there a point of no return in med school and residency where you have a student that comes so far, but it's like, well, I mean, you're in it now. Like it's so hard to turn back. The reason I say that is just because how much time is needed to dedicate to medical school, and then by the time you get to residency, like you said, it's at least 4 years, and then you're in residency, and then it's another. Or have you had residents year two, maybe even year three, be like, you know what, I have to make a change?
Yeah, I think it's relatively rare to see people hit the wall late in residency. You'll see more people that hit end of med school or beginning of residency, and that's where they run into problems and they say, "No, I'm out." I think if you are a danger to society, you shouldn't be allowed to pass through. It doesn't matter how much time has been invested or how well you test, right? I mean, you are providing a public service that has real world ramifications for individuals around you, and it's not just you impacting yourself or your own career. It's you impacting the lives of other people. And so I think there's a responsibility that if someone is not capable, they either don't get passed through or they're getting passed through with conditions, right? Yeah, you can go out and practice, but you don't do well in high stress situations. You should not be in an ICU or an ER. You should be in a more controlled setting. Hey, yeah, you're really uncomfortable making some of these snap decisions. What do we do? So I think those matter a great deal. I think the people that I've seen that um, don't continue through, there's not necessarily a through line, but there's a couple baskets that I think about people falling in through. People that got into it for the wrong reasons. They don't really enjoy it as they're coming through, and they find out they don't enjoy it. If they are somebody that has the financial means, or they come from a background that they're not racking up $400,000 in debt, occasionally you'll see someone jump ship late and they'll say, you know what, I don't want to do this. And they can. You'll see people periodically that don't really enjoy it, but they feel stuck, right? They're carrying $400,000 in debt, and there's only so many ways you're going to make that money back to be able to pay off those loans. And so I think that's a concern: is do you enjoy it? Do you want to be in that role? Um, I think that there's some people that hit a wall. So one of my fears coming through medical school, I don't know if you're a big math person. I am okay at math, but I'm not great at math. And I remember getting to calculus and thinking, I can memorize this well enough to get through it, but it doesn't mean something to me. Whereas the people around me that were really good at it could look at an equation and say, this means something. I know what this is going to impact further downstream. I understand how this is going to work. And I always thought, man, what if I hit that same wall partway through medical education? I hit a part of physiology that I'm just like, it's gone. I don't get it. This doesn't mean anything. And occasionally you'll see that. Most of the time, you've had an intense enough educational experience coming up that by the time they're getting to the later years of medical school, they've already failed out, or they've figured out how to adapt and overcome that piece of it. But that's always a concern: is what if you can't get there? I think you can get into some of the more intangible pieces. How do you do under stress? How do you do when you're the final decision maker? A lot of people are comfortable making decisions with a backstop, but it's a lot harder when you're the last person to check off on something. And that is something you don't know until you reach residency or late residency, or even as an attending. You'll see people go, I'm losing sleep over the decisions I'm making. How do I manage this? And that can be a really hard spot to be.
So, having said that, what's an important lesson that you tell residents or med students coming into the field, year one resident? something that they don't teach you or should tell you in medical school, but it just gets overlooked or just doesn't get talked about.
Yeah, I think early on, I think they talk about maintaining your humanity, but it's hard to know what that means. So residency is set up. So most of the time they're working 60 to 80-hour weeks is a kind of a typical work week. Plus, you're expected to do some studying on the side. You don't realize how much protected time you have. Even though people are telling you that as a student, they say, "Hey, I know you're working your tail off. You're coming in. You're checking in when the residents check in. Sometimes you're staying as long as the residents are, and then you're going home to study." But there's a big difference between how you are being pulled multiple directions by nursing and family and so forth. Even if you're a really good student, you're still not the one entering the orders. You're still not the one making the decision ultimately. You're still not the one having every family conversation, and you're not answering every page from nursing when there's things that need done. And so I think figuring out what the extra cognitive and emotional load of that is, and how you cope with that going home. And I think we talk about it, and I don't know that there's a really good solution to how you manage that. But my advice is generally get something on the calendar. It doesn't matter if you are married or in a serious relationship or not in a relationship at all. Having something on the calendar to look ahead to, I think, makes a big difference for people. If you are working long hours, especially when you're under stress, you lose time, right? You kind of like blink your eyes and you did a lot of stuff, and it's one of those time passes slowly during the day because you're so busy, and you feel like you're kind of grinding through these things, and you blink your eyes and you go, "Oh my gosh, it's been 4 weeks and I haven't done anything really sociable necessarily." If you didn't have it already planned, unless if you're a long-standing extrovert, I think people are good at that, but a lot of us, we're geeks of some sort. We went in and did an extra 4 years of school and then did some additional training. And I think that um, figuring out how you're going to manage that matters a great deal. So, like me and my wife coming through the end of med school, getting married, we got theater tickets, right? And so we have theater tickets. And so if you hit Friday and I'm exhausted, I haven't slept, I'm thinking about how bad I want to just lay down on the couch and fall asleep after dinner. And there's already money spent that you don't have a lot of at that point in your life, and you're ready to um, go out and do something. You can't back out, right? Versus like maybe we'll go to a movie this weekend. You can hit right before the movie starts and say, you know what? Let's just stay in. If you got plans with friends, might be able to flake out. You worry about that piece of it, but it's not as committed. And people go, "Oh, I understand you're busy." You have a something set that you've spent money on that's been on the calendar for a little while, and you're a lot more likely to follow through with it. I think for a lot of folks, you've already sunk something into it that's meaningful, and so having something on the calendar that you're going to get to, family gathering. Going to a show, going to a concert, whatever it might be, I think makes a big difference. And so I usually encourage, even the students that come through to start thinking about how they're going to maintain that piece of it for themselves.
Let's dive into a little bit more of the day in and day out role of being a physician. So there's a patient in front of you, family is in the room, you're having to deliver difficult information. The patient and the family is overwhelmed, not just because of the illness, the seriousness of the condition that they're in, but they're also thinking about finances, insurance, family dynamics, emotional well-being. I mean, there's so many things that patients have to deal with when they are admitted into the hospital. How do you as a physician go into that room and navigate the entire minefield that is?
Yeah. So I actually had a student call me out once after we'd had a series of tough conversations and said, uh, "You've got a script." He says, "Not a real script. It's not like a word for word script, but you have a pattern as you go through." And they're like, "I know which part we're at, and I can actually kind of gauge how long we're going to be in here based on how fast you're progressing through," which I thought was pretty astute on their part. But um, mine typically starts with I want to sit down, make sure I know who everyone is, make sure they know who I am. If there's other members of the care team in with me, I want them to know who's with us. And then, if possible, I want to grab a seat or I'll crouch down so I'm not standing up. I don't feel like I'm a hugely imposing person, but I'm 6 foot tall and I'm not a particularly small guy. And so I think that doesn't always play well if I'm just walking in, standing in the doorway. And so trying to have that comfort level matters. But then just asking them if they understand what's going on, what's your understanding of what's happening, and you can figure out fairly quickly what their fixations are because they'll tell you because that's where they'll spend their time. You can tell if they actually understand what's happening or if they're totally lost. And you can understand to some extent if it's a real hard conversation where they're at in the grieving process, right? So when I deliver bad news, whether it's life and death, or even we increasingly recognize that a life-changing diagnosis like you've got heart failure, you've got diabetes, people's entire perception of themselves changes, right? I was a healthy person and now I'm walking out with heart disease, or I'm walking out with this life-altering diagnosis. And you'll watch people go through the stages of grief even with things that aren't going to be fatal, right? And so just letting them lead that conversation is important. I'm a chronic interrupter by nature. I've worked really, really hard to become a better listener. But I want to chime in. I'm excited. I'm excited about medicine. I'm excited about the conversation. And so just shutting up and sitting back, and they'll tell you, right? They'll tell you where you're at, and you can then use that as a launch pad. If it is um, something where there's a lot of catching up to do, family has been out of town, they don't know what's going on, you can just kind of walk through and say, hey, here's what we know, system by system. Let's kind of talk through, because people can work their way through a systems check, right? You go to your car dealership, they talk about, everyone jokes about like getting your air filter replaced, but hey, here's your air filters, and here's what your lights are doing, and your fluid levels are okay, and your tires are doing this. And I think there's some comfort in having that, not just, well, they got COPD and they got heart failure, but they also had a heart attack, and I think they're having asthma, and they've got a pneumonia, and it becomes really muddled. And just being able to say, hey, here's what I know about their heart. Heart looks great. Here's what I know about their kidneys. Kidneys look great. Liver's not so good. And then let's talk about this spot that we found, that I think might be cancer, and we need to have a conversation about what's next. And being able to break that down as well really helps.
So this question came to mind. Do you think um, do you think doctors in general are good at receiving constructive feedback, or do you? What is your take on that? Because you had said you had a student that had noticed like you had a script, maybe it was subconscious in the sense, but how important is it for a physician, especially like an attendee in your situation, to receive feedback? And does it happen enough? Does it not happen enough? What do you think?
Yeah, I think it depends on the person. And I think there's a lot that has to do with who's critiquing you, right? And so if I have I like to think that I'm pretty good at receiving feedback, but I will take negative feedback more readily from a peer than I will from um, the third year medical student, right? Hopefully, I'll still take feedback and do something with it. If I've got somebody that I don't know well, and they're an RT, or they're a phlebotomist or a CMA or something, and they call me out on something, hopefully a good suggestion is a good suggestion. I'll make my way through it, but I know that my at least gut response is going to be different in that moment. I like to think I've gotten better over time taking feedback in the room in real time. But it's different when it's something personal, like, hey man, you're driving us crazy, you interrupt too much, or hey man, you're coming off really badly with these families. I had a this is kind of a random, but it's life changing for me. In Echo Tech, who called me out on interrupting as a student, and that was a moment of like, oh, she's like, you're really bright, you're fun to work with most of the time, but when you get going, you just drive me nuts, and I think you're probably driving other people nuts too. I don't think it's just me. And I was like, okay. And that was a good moment, but I think that probably changed my trajectory on a professionalism pathway. Hopefully somebody would have said something at some point, but I don't know if they would have, right? Because once you get past that med school phase, once you're Dr. So-and-so, even if you're just the intern, if you're not driving your attending crazy enough to say something about something like that, someone might not pull out something that's that specific for you.
To shift back to uh, the family in the room, what tools are available in hospitals to help patients and families manage that overwhelming stress of a hospital stay? Because you are the attendee, but you have your role. You, at least it shouldn't necessarily be your place to contact insurance or do home care or figure out outside resources for a patient? I know sometimes the lines get blurred a little bit, but what resources are there available for that patient that is feeling overwhelmed with just the overall sense of being in the hospital and receiving that life changing news?
Yeah, I think it'll vary some by facility, and I think there's a lot more attention paid to the holistic approach with peds and child serve and things like that that'll come through in child life services than there are with adults. But I think being able to say with confidence, yep, I got a whole team around me. Uh, Someone from the financial team's going to come through. They can talk through what does this mean for your insurance, and get you some estimates. They can have conversations about what does a payment plan look like, which is going to vary by facility. um, I think knowing that we've got case managers, I always tell them they're saving humanity one person at a time. They're moving mountains every day. They know the ins and outs of the system, right? What insurance is going to pay for, what home services, what home equipment, what hoops do we have to jump through. And so I think that expertise is phenomenal. I think when people are really stressed out, we don't become nicer. And so I think that the odds of having a negative personal interaction goes up the higher stress the situation is, whether it is between the patient and the provider or the nursing staff or someone else who's in the room, or even if it's just perceived one-sided from the patient. They're just unhappy with where they're at with everything, and they pick on one spot and they say that person, all of my frustration and fear and everything is going to be tied in. I think having a really good patient advocate matters, right? I think the patient needs to know that they've got their patient bill of rights and they've got somebody through. I think being able to kind of provide that sense of transparency. Hey, we're all on the same side. We want you to do as well as you can, given the circumstances that we're at. I think matters. One of the sayings that I'd picked up from a hospice doc back when I was in training was, this isn't the path you expected to find yourself on, but you're on it, you're not alone, and we will walk it with you wherever it gets us to. And I think that that's really helpful. I think letting people know that they've got that sense of a team is around you. We're episodic. I'm not going to be here every day for everything, but knowing that we're there for you, and all of these concerns matters, and then you just start chipping away.
You also do outpatient work. You're not just inpatient. So you have your clinic, like you had said earlier. A patient comes into your office, hasn't been seeing the doctor for about 20 plus years. How much time do you have with a new patient when they first come in to see you?
Yeah, so I'll slot out 40 minutes typically. If I have someone who is um, really complicated, or they just need more time, there's a couple ways to manage that, right? Whether that is I'm going to set up a series of shorter appointments, which helps a lot if somebody gets easily overwhelmed, right? You have some people that come in and they know they've got a lot of stuff going on, but they're easily overwhelmed, and so trying to address three problems or two problems in a visit is sometimes not feasible, right? They shut down, they say, hey, this is my big issue. And you start trying to get a second one in, lines get crossed, and nothing happens. And so for those folks, I'll make frequent visits. If I got someone who I know needs more time, they'll be my last one in the morning. And so if it bleeds into my lunch hour, fine. Or they'll be my last one in the afternoon, so I can block out that time. And I think that personalization helps a lot. I had one patient, the first time I met her, she walked in, and I asked her what she was there for, and she just started crying. And she said she has so many problems that she knew I was going to be late for my next patient, um, which was memorable. And she had a lot going on, and so it became this like, hey, I'm going to get you back for. On top of it, she had some transportation issues, so it was, I'm going to get you a large chunk of time every couple of weeks, while we work through this. And it's a little counterintuitive. My office staff are all saints, but I'll add patients on when I'm on inpatient because I can stop by 1 o'clock, whatever, and I can swing up and say, hey, I'm just going to walk across. We're all in the same building. And so I'll warn patients that if I get pulled away for something in the ICU, I might have to cancel their appointment. I think I've had to run out of one add-on appointment in 10 years, where, code bells went off and I was like, well, got to go. Sorry. We'll reschedule you. But generally speaking, I can break away for a chunk of time and help address their concerns, and so that actually creates some cushion.
So my next question is, how do you manage this patient workload? So 40 minutes for a new patient, but then obviously you're seeing your regulars, I guess you'd say. At the end of the day, what does your end of the day look like? How do you make sense of it all?
Yeah. So I think some of it gets a lot better with experience, right? I think there's um, established patients. There's periodically a curveball, right? Probably most days there's at least one. Uh, that wasn't what I was expecting, but most of the time, if I'm following them for diabetes, heart failure, whatever it is, or even if they're polymorbid, right? They got lots of problems. I know them well enough, and I know their med list well enough that I can walk in and say, I know that my next step is to adjust your heart failure regimen, to up titrate. I know what I'm going to do with your meds. We all develop our favorite medication regimens, and so there might be a bunch of different ACEs and ARBs out there, but I know that I'm going to lean into lisinopril and losartan principally because that's what the formularies locally cover and have covered consistently. So I didn't have to put a bunch of people on, I don't know, benazepril or whatever. And so you develop these habits that makes it a little bit easier. You kind of know how you like to escalate the problems that you see on a regular basis, and that makes a difference. Um, I remember watching as attendings would go through, and you as a student you're seeing one or two patients in the hospital, and as a resident you're seeing 8 to 10, and then as you work your way through and you're looking at the attendings and they're carrying 15 to 20 patients, you're going, how do you walk in and do it? And part of it is just you develop so much muscle memory for how you like to manage these things, and you um, memorize the algorithm. So you've got more time to spend on the outliers, right? And that's how you get through it.
Do you deep down, do you know there's a better way, but it's more of like, this is what we got. This is the system that we have to work in. We're going to make the most of it.
Yeah, I mean, I think the biggest obstacles that I run into, we're not running a maximized profit model where I'm working, and so that makes a difference. If I was trying to churn out a patient every 10 minutes, you don't want to see complicated patients in that moment. You don't want to be seeing a lot of patients that need language lines or have learning disabilities. Because you can't realistically get through the material in that time frame. Versus if you got someone who is well controlled on two medications, you can churn through that pretty fast. You're waving, you're sitting down, you're smiling, you're asking if they got questions, and if they got no curveballs, you just kind of follow through with the routine plan. I think as far as what makes it like better system wide, I think people knowing they've got access matters. We're not really built um, to fine tune, right? Because the motivation for how do I maximize profit or how do I get the most patients seen is never going to be the best for the individuals that are the most complicated or have the most need. And so I think finding that balance is hard. I think we do uh, okay, but I think that we could do a lot better with some of those additional, outside supports, whether that is better access to home nursing, or more time to say, yep, we're going to pay out. And I know they do additional coding pieces for extended time frames and things like that. And so I think that helps. But I think the coding system skews towards seeing as many healthy people or minimally ill people as possible as fast as you can, which doesn't all address all the concerns out there.
So there's so many different things as far as medicine and the um, political decisions that are made. I mean, that could be a whole podcast in and of itself. We're not going to be able to touch all of it, but rural hospitals seem to be taking quite a bit of a hit in recent times. So I was overwhelmingly rural. When a rural hospital closes or has to cut services, what's the downstream effect on patients and communities? How does and Broadlands isn't even that big of a hospital, to be honest, but how do the larger hospitals uh, get affected because of the John Doe Hospital in rural Iowa has to get shut down just because of funding and et cetera, things like that.
Yeah, I think it condenses down care, right? So people who previously could be hospitalized and taken care of in their own community now have to come in. I think subspecialists have been a problem for a long time, and so there's a lot of the groups that have satellite clinics, right? They'll go out, or with the advent of better technology, being able to do some of those things with remote access has been really helpful. But I think that there's obviously things like surgery, delivering babies, um, conditions where you need to lay hands on or really get an in-person view of anything from a rash to a good check over of a joint. You can't do that through a computer screen, right? I can do probably 75 to 80% of what I do on a daily basis as a general internist. I could do remotely if I needed to. I think I'd lose a lot of the personal touch, but from a pure, can you do the work and can it be efficient? You can do that. I think that we lose out on people being able to get the care that they want from another human being, and I think that some of the high risk stuff is the stuff that unfortunately you really need a person for, right? You need your appendix out, you're delivering a baby, you've got a trauma. And having to go 2 hours for care is frightening, right? You have one friend or a family member that has a bad episode. You start thinking, well, I like living here. I like my neighbors. I like my job. But what if that happens to me, or what if that happens again, or how do I get care for these things that I need? Cardiac stents, whatever. And so I think that weighs in a lot. And then I think that load then shifts to the hospitals that were built for the metro area and a little bit outside, but we're not necessarily built for additional outlying space. And as more of those outlying spaces have to funnel in, you just watch the numbers rise even as the population in the metro goes up. And so that's an issue. I think one of the pieces that's maybe um, not as well connected to that shrink down is the loss of EMS services, right? And so you get to a situation where there's just not ambulances available for some of the transports that you need, and if your ambulance services from the metro area are now having to step out to some of the rural areas, or it's a longer transit time back and forth to take care of these things. Now, even getting a hospital transport in town during busier times can be really difficult. And so I think understanding it's not just the physical presence of services, even the ability to transport patients to the next spot becomes harder as you lose those hubs. And so I think that's a concern long term.
So you've had now two perspectives. You've had the CEO perspective, you have your physician perspective. Now that those two have intertwined, uh, do you ever see yourself thinking about the CEO decisions as you're practicing your medicine, or did you, while you were the interim CEO, did you find yourself thinking about uh, the medicine hands-on approach while you were making CEO decisions?
Yeah, I think the while making executive team decisions, just knowing, hey, how's this going to feel in the trenches, so to speak, really was informative. Being able to say this is a change that is probably going to get some groans, but is not a great shakeup versus other things that might seem small if you're not the one doing the workflow. And then you think that's a problem. My favorite is every click kind of makes us want to play in traffic. And so when you guys are talking about, well, it's just 5 more clicks, or it's just 3 more clicks, it's like, well, it's 5 more clicks for 20 patients every day for the rest of my life. And so and they don't tend to remove clicks, right? They don't say, hey, I'm giving you these 5, but I'm going to take this from the other side. It just adds up. And you get the same thing with paperwork and modules and training, and it sounds good, but there's only so much bandwidth. And I think knowing how much time you're actually taking away from bedside care really informed that side of it. And how's this going to feel when you are working 60-hour weeks or 80-hour weeks, and someone says, well, it's just 5 more minutes. And you're like, I can't do 5 more minutes today, man. I got to go home. Mattered, I think, on the day-to-day working, knowing where the money goes and how some of the bigger ramifications play out matters. I think a much greater appreciation for the value of um, complete systems, as far as having really organized standard operating procedures and workflows and some of these things that just when you get pulled away from patient care, you're trying to get to a meeting so that you can go through another memo or another order set, can be a little bit hard to make that pivot, right? Because you're thinking, man, I'm supposed to be in room 302 doing something. I can't be here having this conversation. Like, I got stuff to do. But the importance of having those systems in place matters a great deal when you are onboarding people and when you're creating a kind of a cohesive culture. I think we talk a lot about things that drive burnout, and I think that the areas that you'd see the biggest burnout a lot of times are areas that they become low trust. Right, people don't believe that the person next to them is going to do the right step, and so they're not only doing their job, but they're also double checking the other person's work or questioning the other person's work or trying to fill in for two jobs or three jobs. And so I think having good systems in place to that you can reliably say, hey, even though this is a relatively new hire, if they just follow the procedure, we've got good procedures in place, and if everyone does their job, we can make this run. Right? You see that played out in CPR. Right? You go get the AED, and it's so silly in class, but then when you're in the real world, if people aren't using that closed loop communication, or if people aren't following the standard algorithm, it just creates chaos, right? And you'll see that happen in slower motion and less acute settings. You can watch that carry over, and I think that I have a much better appreciation for the value of those pieces. And then on the clinician side, the limitations of what you can legislate from the C-suite.
So, having both sides of the coin available to you, um, you still keeping in track with just the kind of uh, policy side of healthcare. Are there trends that worry you for the next 5 or 10 years? And but are there other on the other side of that? Are there trends that you see happening that give you hope for providing more well balanced healthcare for the state of Iowa in particular?
Yeah, I think the I'll start with the positives, I guess. I think there's a bill that recently went through. I don't know if the governor signed it yet. That helps to trim down some of the prior authorization processes, especially for things that we think of like routine care for cancer screenings and so forth, which I think is a good start. I think the fact that those conversations about where is the time going, where's the administrative burden, how is that negatively impacting provider career longevity and total cost and patient care, is good. I think that it's the fact that it's reaching movable bills and not just lip service saying, oh, we need to do something about this, is encouraging. And so I think that that trend will continue to play out as we figure out um, what are the goods and the bads with AI, and how do you balance what are we trying to actually deliver for a product with insurance business, right? Because they've got a right, an obligation to run a business, and so I understand that. But I think being able to have that conversation at a high level really matters. Things that are a little frightening, I think the loss of trust, some of the backlash from COVID-19, in particular for uh, who do you trust for your information, and how do you balance out public health with individual choice, has been a tension that's been around as long as people have been talking about public health, but it really pushed things farther the other way. I think having uh, I guess I don't mean to offend people in power, but non-serious candidate for attorney general and things like that are concerning to me. Right, you're taking people that don't have a depth of clinical practice experience and saying, "Hey, we want you to be in charge." And I think that some of those um, trends are blossoming out of that sense of, well, we don't trust the powers that exist, and so if we just rip it up or throw somebody in with a different perspective, maybe we can solve this. And I can understand that urge, but I also fear where that leads us.
And now, speaking of COVID, probably the biggest medical event to occur in our modern history, I would probably say, as far as like what we can remember. Where do you begin? Healthcare burnout, staffing shortages, the lack of transparency that we were seeing, rising cost. Do you agree that COVID really changed the perspective, not just from general population standpoint, but even from a healthcare standpoint? That like that's where the line in the sand is drawn now. Like looking into the future of medicine.
Yeah, I'm going to be really curious to see what this looks like in another 10 years. So 2020, people that were uh, coming through college then are all going to be launching into residency now, right? And so the first couple of years of the pandemic, it was, hey, what's the fallout of having people in training who missed out on some of their clinicals before they hit residency? And what does this do to the residents as they've gone through some fairly horrific and harrowing things during a kind of chronic, high acuity, high census world? um, and what does that mean? But now I've got people coming through that they were going to be in undergrad at that time, and then soon it'll be people that were in high school. And so their perspective on what it meant to them is going to be different because they didn't have the clinical thing. They might have family members, right? But it's going to be a relatively small number that are going, oh man, that was so horrific in the hospitals. They're going to go, oh, I remember I had to learn remotely, or I missed prom, or I had to cancel my vacation, and it's not the same. And watching even the current group of residents come through, they didn't see a bunch of the acute respiratory distress syndrome ARDS that we saw for a couple of years straight. That was just all there all the time. And now we're, patients come in, they get influenza, and you've got people that are going, oh, they've got this kind of patchy diffuse pneumonia. And you're like, well, that's ARDS, early onset ARDS. Please don't give them any more fluid, and let's take a second and step back, and you talking through what that means. And I remember shortly before things really blew up with COVID, talking through and having a patient come in with non-COVID ARDS and showing it to the residents and saying, this is what we're looking for. I know there's a bunch of journal articles and whatever, but in the real world, this is what we're looking at. Um, and seeing that 5-6 years later, we went from I haven't seen a whole lot of ARDS. I don't have a lot of experience, and then all you see is ARDS, and now it's this group that's coming up that maybe just doesn't have that same experience. And so that'll change us and bring us back to the mean. I think those of us who were in practice at the time, especially if we were maybe mid career, right, the people that were end of career are kind of working their way through. And they'll have a story about that patch, but they're not going to be the decision makers for the next 20 years. And so I think folks in my generation a little behind. It'll be curious to see how everyone adapts, right? But even watching as we went from oh my gosh, really to talk about supply chains, right? I never cared about supply chains until 2020, and all of a sudden I was in meetings a lot of times early on, multiple times a week about where are we at for gloves and gowns, and how are we going to manage this.
I was just about to say, I was like, where do we get our medical gloves from today? Like, or I'll have to. You're telling me I have to keep my gown for the whole shift? That's wild.
Yeah, we're trying to figure out how to preserve masks, and people are hanging them in their rear view mirrors, or putting them up to get lasered by one of the cleaning robots, hoping that it makes some difference, right? And trying to guess how good your seal is after 7 days in an N95 is a different experience. I think that uh, long term, a lot of it's going to revert back to the mean, right? Because the business pressure of how do you efficiently and cheaply get your goods is going to matter. I know there's a lot going on with tariffs and so forth right now that might play a role in reshoring manufacturing, but realistically, I don't think that's going to be the long term trend. I don't think we're going to be making all of our own drugs and medical equipment in the United States in 30 years. I just don't think that's going to happen. And so I think some of those concerns are going to slide back. I think the lessons learned about how we manage complex systems and what do we do when we hit our surge plan and stay there for months sometimes. I think those lessons unfortunately get lost pretty quick. And so I'm hopeful that we'll hold on to those. But given that even with a couple of slow years, you start talking to people about, hey, what's the plan with the isolation cart? What's the surge plan? And you feel like you're kind of walking through wet sand to get people back on track. It's like, hey, this was muscle memory 5 years ago, and now it's just feels like ancient history when we're trying to make those processes move. And so I think we'll probably come back to something that resembles what was normal before. But the downside is that also means that the next time there's some sort of a disaster, which will happen eventually, hopefully I'm not going to hit a second one in my career. But when it happens again, I don't know that we're going to be any more prepared than we were before.
Yeah, how quickly we are to forget about the just what a tumultuous time that was. Um, uh, on a personal note, I look back at COVID and it was wild. It was very crazy in a negative sense, but uh, not to be impersonal about it, but what a amazing learning experience it was, though, for everybody for sure. But yeah, I remember taking my N95 and having to staple the bands on it because it keeps snapping, and I was like, "Well, this is the only
This is
one
all
I
I
got."
got. Yeah, resupply's not coming for a while.
Yeah, yeah, until next week at least. Then just like, oh man. But ours that was a good point too because I remember prior to the pandemic, as a respiratory therapist, I honestly wouldn't see ARDS too much, and when I did, I was like, oh man, like here we go. But then COVID came, and then just got such a crash course on all of that, and now I see ARDS, and I'm like, oh yeah, okay, not, yeah, we'll do this again, not a big deal. Um, all right. So COVID, you hear about COVID. It isn't in the U.S. yet, but you're hearing the initial news of what's happening overseas. As a physician, what were your first thoughts? Were you optimistic that maybe it's going to be contained over there? Because we COVID's not the first disease that you hear about in the news. Like there was like Zika and West Nile and all those things. I mean, those were very serious in itself, but they weren't quite like COVID. What were your initial thoughts upon hearing the news that this was starting to become more and more of a real thing?
Yeah, I think anytime you hear that there's some new disease or some very frightening disease that's got an outburst, you always hope it'll pass you by or it won't break containment. I remember being not in medical world yet when the original SARS or what the SARS and MERS and some of these other ones that were out there, and you'd hear about how high the fatality rates were, and there was a sense of, well, how do you contain it? And they're checking people on airplanes leaving these countries and so forth. And every time there's a malaria or sorry, another hemorrhagic fever spike coming out of any location, there's a series of messages, and then they make sure that everyone knows the containment plan and how are we screening and who fits in the Tyvek suit. um, and so with this, it was very much a sense of, okay, well, let's see what happens. But I remember before it had really broken into the news what was going on, there were I don't know if you're a news junkie. I tend to read a couple sources, and I don't know, it's I've got very boring hobbies. Uh, but there were reports coming out of China about them standing up these hospitals in no time flat. And there was speculation about if they were doing military exercises, and did this mean they were going to, I don't know, invade Taiwan or whatever. And why are they standing these up? And then it was, well, is there some sort of local outbreak? And it was like, oh yeah, there's a local outbreak. But I remember that being the first like, what is this? And my father-in-law is a military historian, and he's a news junkie, and so I remember chatting with him a little bit just in passing about, wow, that's kind of a weird thing to do, right? Is to stand at these large scale hospitals in very short time. Um, and then as it became clear that it was a real thing, that was a problem. Then it was, well, is it contained or not? As soon as it became clear that it wasn't contained, the assumption then is that it's coming to us, right? And so I don't know if you remember this kind of this eerie kind of calm of, yes, it's out, it's in Europe, it's bad. Hey, it's on the cruise ships. Hey, it's on the West Coast. Yeah, it's probably here already. We're just having a hard time detecting. Testing was so sparse and hard to get. Um, and then there was the shutdown and the, hey, we're gonna prep for this because we're confident it's coming, and how do we bend the curve back down so we don't get overwhelmed. And everything was just silent at the hospital for a little while there were a couple of weeks, maybe a month, of just what's going on, and New York was on fire and we really hadn't caught it yet. Um, and while you're prepping and bracing for it, there's only so much you can do, because early on there wasn't the testing that you would want to have. There wasn't the supply of materials you'd want to have, and so trying to determine all that was a wild. I just remember going on. I think it must have been spring break, or a long weekend right before everything hit, because it was before spring break, because spring break was the endless spring break for my kids, so it would have been end of February.
It was, I think the official shutdown because my wife was still teaching at the time was like Friday, and then that weekend was supposed to start spring break, and they never went
They
back to
went back.
school.
Yeah,
Yeah.
yeah. So my kids talk about endless spring break. Their memories are mostly positive, thank goodness.
Yeah, right.
And so, but I remember we had a plan to meet up with family in Minnesota, and my wife had asked me a couple times, like, "Hey, like I keep hearing all this stuff, and people are canceling vacations and flights, and like, should we still go?" And I said, "Yeah, we should still go. Like, one, it's not necessarily here yet, but I didn't tell her this, and she kind of hits me for this. But I in my head, I'm thinking, well, what if my family doesn't make it through? What if my parents don't make it through? They're in pretty good health, but they're older, and I knew they were in the high risk category. And I was like, yeah, I'm going to go up to Minneapolis. We're going to see people and do this. And while we were in Minneapolis on vacation, is when the first cases in the Midwest were confirmed. And so my drive back from Minneapolis, in my head, I was going through hey, what are all the things we need to do at the hospital, from my perspective, and how do we start marking out that first page or so of plans, because I know we'll be having meetings on Monday.
As a speak, um, to stay a little bit more personal, were you making a contingency plan for like you and your family because you're going to the hospital every day and you're seeing patients with COVID? So like, was there before we knew like the big picture, right? Of like, okay, how serious is it? What age demographic is it affecting? Like, what comorbidities does it seem to be uh, tying to as far as like a higher mortality rate? Were you personally starting to kind of make a own like family contingency plan, or were you more hospital focused?
I mean, there was they had a few young docs die in Italy. I want to say that really hit the news and hit. I'm not on social media, but people that are on social media are like, "Hey, did you see this?" There's residents or people in their 20s and 30s that were dying from it, even though that wasn't the bulk of deaths that was happening, right? And that was enough to get your attention. And so I certainly made sure that we had a spreadsheet with, hey, here's the finances, here's the accounts, here's where everything's at. We didn't redo some huge, bug out plan or anything like that. But there was certainly hey, if I get sick, here's where the disability insurance is. Here's where life insurance is. Here are the things that you need to cut off right away, right? These are unnecessary expenses. For the first couple of months, you got to ditch those until you see how this shakes out. And so we had that lined up. We didn't spend a lot of time on it, but I did have a spreadsheet essentially ready to go for that. But otherwise, there was just the sense of you go and you go for it, and you know that your percentages are still in your favor as a youngish, relatively healthy person, that even if you catch it, you're probably not going to die from it. And so there was trying to balance the cautiousness with that.
Yeah, I remember um, my role as a respiratory therapist. I saw COVID patients all the time, and I wasn't at Broadlawns at the time. I was at Methodist, so I was seeing a way higher percentage of patients. But my wife was pregnant at the time, and then there was still huge questions about, well, how is it going to affect women who are pregnant? And so yeah, I quarantined for like 2 weeks, like kept uh, isolated from them until we kind of got a little bit of a better sense. And then finally, I was just like, you know what, forget this. I can't do this the whole time. I'll just, wash up. I'll change in the garage, throw my clothes immediately in the washer. Like, don't even bring my shoes in, all that stuff, or like get dressed at work. But yeah,
Yeah, I slept in the
what a
basement for a while. I There was very much this, like, it pretty quickly became apparent that just not, right, I got young kids at home, and just not being around them wasn't an option. Being around my wife was not an option. And I wasn't gonna, sit in a corner with an N95 away from everybody just because I'd been at work. And so the kind of the compromise was, there was maybe a little more tendency to side hug my kids, and a little more tendency to do that. But I know we'd set up a spot in the basement. I was like, if the bulk of my time that I'm going to be right up around you guys is when I'm upstairs, we're all sleeping on the same floor or whatever. I took that pretty seriously, especially the first part.
All right, so we're gonna shift gears here again. So there was um, a new report, interim findings report, key drivers of cancer in Iowa project, and looked at the years from 2018 to 2022, and it showed 87 of Iowa's 99 counties had significantly higher cancer rates than the national average. Now, there's several lifestyle factors that go into this, like obesity, alcoholism, food habits. Um, but I sent you the report. You looked at the research. I was currently ranks Iowa currently ranks second nationally for age adjusted cancer rates. I don't know, to kind of look at the forest for the trees, right? I mean, we're not going to really be able to get into specifics so much, but you looked at the research that they found. Anything that stood out to you about that? Anything that's alarming, or maybe something to uh, look says that we need more context about these certain aspects? What were your thoughts on that?
Yeah, I think it's good that they're taking a serious deep dive into it. I think it gets hard because as you dive into some of the county by county, if you've got a smaller population, any outliers are going to stand out, and they wouldn't necessarily be as substantial as they are with a larger population. So knowing that you're going to get some variation that way matters. I'm really curious. I think it creates a good jumping off point for research, right? For them to be able to say, hey, here's a type of cancer that's more prevalent in this area. How much of that appears to be familial, how much of that holds true if people are moving into the area, and hopefully if you're tracking people moving out, do they maintain that risk when they leave, or what age they leave, and then just looking at it, how much this has to do with water drainage, how much of it has to do with soil patterns, and what's in the soil as we're kicking things up, plowing and so forth. Is there a way to attach it to what chemicals we're spraying on fields, or how we're doing business, which in Iowa is a large portion is agricultural. And so I think um, that's kind of an intriguing setup. I think, especially since it is higher than neighboring states, where you still have, how do we compare to Eastern South Dakota, Eastern Kansas, Eastern Nebraska, where you're going to have a lot of the same crops, right? It gets a little bit harder to say if you are seeing things that are tied in with what you're using for those crops versus ranching, right? Which is going to be the western part of those other states. And we don't have as much of that in Iowa, right? We certainly have cattle and hogs, but it's not quite the same as going out to, I don't know, western North Dakota. And you're just not going to see some of those same risk factors in there. I always wonder a little bit about what the familial piece is, right? Not an inbreeding joke, but there's certainly smaller, lower population areas where there's disproportionate representation from some family trees. The half joke is, if you're interested in dating somebody, when you're getting to dating age, make sure you check in that they're not a cousin or related somehow, that maybe you don't realize at first glance. And so I think that closeness matters, right? So if you have a big spike in pancreatic cancer or breast cancer or something in an area, how much of that has to do with familial tendency, and how much it appears to be environmental. And I think they're still parsing through pieces of that.
So, as an individual, patients that you have, there's only so much that they can control. Okay, but the things they can control, this might seem like general information, but as a physician, what are you like? What are the things to look out for? What are the things to avoid? What are some things that you're telling patients in your offices?
Yeah, I think it's helpful that a lot of the evidence out there doesn't necessarily point to some super restrictive diet or some wild, um, Tom Brady esque. I've got to sleep in a ISO chamber and eat haven't had fresh fruit or strawberry sugary fruit in forever, and can't eat candy and can't have any of these things. I think knowing that you can do things in moderation, I think there's pretty good evidence that looking at a DASH diet, if you're not wildly turned off by dropping the salt. I think we all got to drop our salt content, but getting closer to that helps. I think that following something resembling a Mediterranean diet, where it's more fresh fruits and vegetables and nuts and so forth, has recurrently shown out to be a manageable way to live, recognizing that there's cost associated with that, right? The cost of going out for fresh fruit and vegetables and so forth, versus purchasing something that's more processed and is not going to go bad on you if you don't eat it fast enough, really is a struggle. But I think looking at those pieces, talking about moderation in particularly processed food. I know the new food guidance coming out is a little more red meat heavy, and so you have some concerns about what does that do as far as heart disease. But from a cancer risk, I think red meat's got some risk, but it's maybe not as well established as nitrites from hot dogs and bacon and things like that. That um, we're pretty confident our drivers. Doesn't mean you can never go out for something like that, but it just means trying to figure out how you mitigate those pieces matter. I think good exercise matters. I think having awareness and access, right? If you think something's going on with your body or something has changed substantially, you're losing weight and you don't know why, you're developing leg swelling and you know that it's new for you, getting in and being seen, changes in your bowel habits, any of those pieces matter, and I think help people to get in and get screened early. But as far as prevention, a lot of it is a little more nebulous.
I think you heard the news. Jayco recently put into one of the things they're going to be looking for is the um, staff ratios, nursing ratios to patients. To me, that seems a little bit more easier said than done. Um, Initial thoughts on what they're hoping for, but then what's realistic?
Yeah, I think there's some real supply demand issues, right? I think that we saw with an increased need for nursing during the pandemic when people are at a high census on a regular basis. Um, I know locally we were able to kind of run the math and say, even if you bring us more equipment, we are going to run out of nurses before we run out of everything else. And when we run out of nurses, we can get them by paying a lot more to siphon them from somewhere else who is now short, and now they need to bid up to get more nurses. And so I think short term, that's going to be maybe a driver of costs. It'll be a windfall to the nurses, which is good for them, but it's tough on the system as a whole to carry that expense. I think that figuring out if those lower censuses matter, or sorry, lower the improved staffing ratios, a lower patient to nurse ratio is going to substantially improve nursing career longevity. Would be kind of one of the key factors, right? Because if you're training people in, but you're not retaining them because it's still a tough job, I think is going to be an issue. I think that we are relatively sheltered in Iowa when you hear about strikes happening in New York or elsewhere with nursing staff, and you hear about the staffing ratios they're running with. It's wild to me, right? Those are ratios that we would never run here, 15-1 and things like that. That I can't imagine doing that for a prolonged period. And
Just the charting alone would just be
yeah,
bonkers. I
yeah. I
don't know
mean,
how you'd keep up.
the ability to spread your time. I can see 15 and 20 patients and so forth, but it's because I am. Uh, I think a key part of the healthcare team, but I'm not the one at the bedside providing that care. And I'm not going to pretend that I'm the one spending the most time with that patient. And so, um, as you start to divide out how much time is available to see the patient, make the phone calls, do the charting, participate in care, I think those protections matter. I don't know how much it's going to impact us locally, given that our staffing ratios are not a negative outlier compared to some places.
Yeah, I think a lot of people don't fully get a good comprehensive look into the daily life of a nurse. I'm sorry, but I have yet to see a medical drama on TV that actually displays what the accuracy is of a day-to-day work shift for a patient is, because you're as a nurse they're answering call lights, they're refilling waters, they're helping people get up to the bathroom, and obviously you have techs that are helping do that as well, but they're talking to family members, they're the mediators between you and the patient a lot of times, and then you know plus looking at orders, perfect serving the docs and trying to communicate well, times that by 15. That's crazy.
Yeah, it's nuts. I think it's a real tough job, and I think there's a lot of um they're not necessarily. I know there's not they're not necessarily making the decisions, but they are an early alert system for a lot of things, right? If there's a change in that patient, I'm going to see them, and then I might not see them again until the next day, and I'm relying on the nursing staff to identify that change, recognize that it's a problem, and reach out. And that requires a lot of mental throughput, and a lot of willingness to try to separate out, here's the concern, and I know that that's huge, and the idea of trying to do that while keeping all the other tasks online is wild. So I think there's going to be limits. I want to see what final rules are out there, and what that compares to what we're actually running. But I didn't realize how, even in non-COVID normal times, what the staffing ratios were like in some of these facilities, not locally, but on the coast, until I was reading something about the strikes, and they were like, "Oh, we're worried about our ratios," and I was like, well, "How bad can it be?" And I was like, "Oh, it's bad. It's really bad." So
And then I don't know if this might be false information, so somebody do the double check for me. But Noah Wiley, the physician from The Pit, the actor, he's a huge healthcare advocate for like nursing like rights and things like that. But he was telling me, or he was not me. I don't know the guy. I wish he was on a podcast and I was listening to it. But I think if you assault a bus driver, it's a felony. But then if you assault a healthcare worker, it's not. And I don't know if that's changed ever since that podcast was released. But yeah, he's gone on Capitol Hill and he's spoken because his mom was a nurse, and he's spoken up for healthcare worker rights and things like that. So yeah, no, it's I'm very curious to see what JCO does. I know like the intention is there, but I'm very curious how they're going to actually implement that, especially post COVID, because I think that really opened up people's eyes as to what the the worst case scenario can be. And I think unfortunately, I think it's probably had a negative effect on the future of healthcare and like workers, not just physicians, but nurses and RTs and techs like that for sure.
yeah, I think the concept of having a safe workplace, and how do you balance out, um, what's the appropriate degree of kind of punitive measure to take, and if the problem is that you've got people that are delirious or having a psychotic break, or on drugs, and they assault somebody, is what's their level of liability, and how do you balance that with the need for your staff to feel safe. And I think it's a really hard spot, for people to draw lines, because it does become this, like, well, obviously they assaulted somebody. If they did the same thing on the street, or assaulted their bus driver, um, no brainer, straight to jail, and let's talk about your fines and talk about your restitution and so forth. Or banning them from the premise. And then if you get into the, like, hey, this is someone who's got serial issues with, whether it's substance abuse or psychotic issues, or just a belligerent person with health problems, how do you balance their health care needs with staff safety? And it's a very tough spot to be. It's a tough conversation. I think it's one that comes up not infrequently at every facility, and I'll be curious to see where the conversation goes.
Yeah, I'm very curious too. Um, Last topic of the day, and then we'll let you go. Not like it's an important topic. Artificial intelligence and medicine. So these past 3 years have just seen a huge advancement in what artificial intelligence actually is. Like coming into the sense of like, okay, what we think about like in the movies, right? Like we actually have some sort of um, application that is able to respond to us in probably the most humanistic way that we've ever been able to. But technology, medicine, they very much go hand in hand. I mean, we see cutting edge tech being developed out of the necessity for to save human lives. So AI though feels like a completely different frontier. I mean, right now, like we have robots performing surgery, but it's under the guidance of a human. We're able to do language translation. We're able to speak, and have our notes just come right onto the page. But AI is different. I don't think we've ever seen anything like AI. So, what excites you? What concerns you? Um, what is there to look forward to for like the next generation of physicians that comes in? I mean, it's going to be a completely different. It's going to be a game changer for, like you said, those physicians that grew up during the pandemic and now they're entering med school. It's gonna.
They're entering a world where AI has just been available for local transcriptions and so forth, and we're just hitting the first generation that really does that, right? So some of the first ambient listening technology that came out looked really good, and then the secret was that there was some guy on the other side who was taking what the computer was putting out and then correcting it and then spitting it out on the final product. And that's
Oh
why it took
wow.
5-10 minutes. They were doing it in real time. They're fast at it, but it still wasn't
True.
truly
Mhm.
independent of humans. Whereas the stuff now, I'm kicking out into my phone and it kicks out a note that the quality is variable. Figuring out the best ways to use it, I think, is still working, but I think that matters. Getting it to a point where it is meaningful beyond a cool uh, party trick is going to be tough, right? So when I was first in training, we were still on paper charts over across town, and you would dictate into a phone and a human being would then transcribe it, and soon after you would have a transcription um, typed out by a human being, more or less vetted by a human being before I saw it to vet it and sign it. And then they said, well, that's expensive, we're going to move to Dragon, which is good but it's not perfect, and it doesn't reconfigure my thoughts the way a transcriptionist would. If I said, oh, please go back up to wherever, Dragon would just type out, please go back to, and it wouldn't actually solve it. I could get better with some of my cues to get it back and forth in the node, but there's still a lot of manually clicking with a mouse and deleting and so forth, that just was not as good as you'd want it to be. And so more people started picking up human scribes, which would do essentially what the transcriptionist had done, but in real time at the bedside. And now we've got AI. And so I think if it gets to the point where it is truly cost effective, right? Because a lot of these companies are running at a loss, and so we're not actually bearing the true expense of it. I think that if they can make it cost effective and more cost effective than having a scribe in the room, um, it's going to matter. I think as some of these co-pilot pieces come up and integrate, where I say, hey, I want to order a BMP, a CBC, and an X-ray, and it puts it in and it's ready for me to review and sign. I think that will help. I think if you can learn how to auto-populate the problem list, right, that'll matter. That's still a very manual process. I still have to go back through everything and type these pieces in so the insurance gods can see my work.
Insurance guys.
And so and so all these pieces matter. I think people worry about job security, and I think the couple pieces that I would want to see before I thought, one, this is really beneficial for human beings, and two, oh my gosh, maybe I need to find a new line of work. Um, Early pieces that came out, again, I haven't seen anything recent in the last year or so, with early warning systems for things like sepsis. um, they would provide the data, and companies that would pitch, and they would provide the real data behind what they did. You'd show an improvement in sepsis performance that started before the program rolled out, because they did really intensive staff education. And so it turns out really intensive staff education on a problem we want to address is effective, which we already knew.
Who'd have thought?
And then when you roll out the machine, you say, well, look how much better we are now compared to what we were before the whole process started. But there's not necessarily that much improvement from the time the staff education happened. And nobody was willing to provide me post data on how long that benefit was there. Typically, training wears out after a few months, and so you have to renew it. And so I'm curious on that. And the other one is if they get to the point they can really predictably manage weather predictions, then I'll be worried, right? There's so many variables in the human body and so many pieces going on, that if you get to the point where you can give me a truly accurate local forecast, 5 days out or a week out or 2 weeks out, then I'll have faith that the machine can handle the variables and has the ability to identify enough variables to do a large portion of what we do in medicine. I think we have a lot of variables, and every day we're playing the odds, right?
Yeah.
Of I think this is more likely than that. Sometimes I'm going to treat two conditions, they come in, or three conditions, right? Well, they got baseline COPD, they've got baseline heart failure, they've got infiltrates on their lungs, and they've got a viral infection. I'm going to start antibiotics. I'm going to start treatment for COPD. I'm going to start a diuretic if indicated, and then I'm going to sort out later. But I don't know if I was actually solving the problem with all three treatments, or if I was just treating one of them and the other two were unnecessary, or if maybe the patient was going to get better on their own
Right.
without any of those treatments if it was just a viral infection. And we're getting better at sorting through that, but we're not great at it yet. And so if we see that, you see the weather predictions pop up, Just know at that point, I'm probably rechecking my resume. Um,
Wow. Holy
but until
cow.
they get to that point, I don't have a lot of faith that it'll be able to replace what we're doing because there's a huge amount of uncertainty in what we do. And it's easier for people to pass that uncertainty on through another human being who can sit down and talk and have those difficult conversations than it is to kick it to a computer. Because if I am right or wrong, people at least have a human face to it. I don't know that they're comfortable yet. It might change as they get used to their AI assistants, but yet with a computer doing that and then being right or wrong.
And at least for sure with the hands-on aspects of healthcare, I mean, I think we're still. I mean, I hate to say not my lifetime, but I guess you never know. I think we're still a long ways off for that, for sure. Um, is there anything concerning about as far as like the guy that's first year of med school starting, in August, um, that they're gonna perhaps miss out on because of the AI, or do you think now that there's this tool here, it's like, oh man, you're gonna be so much more efficient in X, Y, and Z now that you have it, as opposed to like when you were in med school, like you didn't have that approach to it.
Yeah, I'm really curious to see what happens. So a lot of the learning early on for a lot of doctors happens while you're writing your notes. You're thinking about it, you're putting it on paper. It's a very exposed profession, right? Because you can see what I thought, why I did what I did if I'm writing a good note. And if it turns out I was wrong, you can see that in real time that 3 days ago you said this was it, you were wrong. Here's your thought process. Why didn't you think about X, Y, Z, or why did you weigh this more heavily than that? And so even just for the fact of saving face, even if you're not in it purely for hey, I want to help everybody, just knowing that you are going to have people watching that, your attendees will see it, your coworkers will see it, the nurses can see it, now the families can see it, right, in more or less real time on their phones. They can pull up the note and say, oh, you wrote this. And I think that if AI starts writing our notes for us, the risk that you're not building some of those thought processes is real. But I think that people will figure out pretty quickly if they're screwing up, hopefully. And so if you're not retaining information, having a conversation about how we retain that, whether that's making people write their notes or having stronger didactics or whatever it is going to matter. But I think that there's some benefit there. I think people that are, no offense to people working in urgent cares, but I think some of the stuff that is more algorithm driven is going to be the stuff that's going to be the fastest to go, even if it's just because you need to walk in as the provider and say, yep, here's what I think is going on. Then AI will say, great, here's your script, here's your next piece, sign off and move. I think you're going to have to get used to running a high volume with a lower volume of people working. And that means some people are going to have to figure out a new career path potentially.
Oh man, wow. Well, whew, things to look forward to. Well, on that note, we're going to call it a day. So, Dr. Kruse, thank you so much. This was so insightful, tons of information. Hey, if you have to play this back, go ahead. I certainly don't mind that. But again, Dr. Kruse, it was a pleasure having you. And hopefully, you'll be able to come back on.
Yeah, thanks for having me.
All right. Well, until next time, see you guys later. Bye bye. Okay, look at that.
That was good.
Woo, that was great. It was, it says 250.